Hypertension is one of the most frequently tested topics in exams. It is defined as clinic blood pressure more than 140 by 90. If any one of these values is above normal, then it will be called hypertension. For example, if a patient's blood pressure is more than 140 but less than 90, it is called isolated systolic hypertension. And if a patient's blood pressure is less than 140 but more than 90, it is called isolated diastolic hypertension. And if a patient's blood pressure is more than 140 and more than 190, it is also called hypertension. In all cases, we will treat it according to guidelines. In 90% of the cases, hypertension is primary, which means that there is no identifiable cause of hypertension. In 10% of the cases, hypertension is secondary to some other cause. The most common secondary cause of hypertension is primary hyperaldosteronism. So the most common cause of hypertension is primary. The most common second cause of hypertension is primary hyperaldosteronism, and the most common secondary cause of hypertension is primary hyperaldosteronism. In primary hyperaldosteronism, the aldosterone levels in the body increase. Aldosterone causes sodium and water reabsorption in the kidneys that increases blood volume, and when the blood volume increases, the heart pumps more blood, and when the heart pumps more blood pressure increase. In pheochromocytoma, the levels of epinephrine and norepinephrine increase, which cause vasoconstriction that result in hypertension. In Cushing syndrome, the levels of cortisol increase in the body, which increase the effects of epinephrine and norepinephrine that result in vasoconstriction and hypertension. Liddle syndrome is a congenital disorder of epithelial sodium channels, and just like aldosterone, it increases sodium and water reabsorption in the kidneys that then result in increased blood pressure. In congenital adrenal hyperplasia, the levels of 11-deoxycorticosterone, also known as 11-DOC, increases in the body, and it acts just like aldosterone. It increases sodium and water reabsorption in the kidneys that result in hypertension. In acromegaly, the levels of growth hormone increase in the body. Growth hormone stimulates the secretion of insulin from pancreas, and insulin, just like aldosterone, increases sodium and water reabsorption in the kidneys. Glomerulonephritis, pyelonephritis, adult polycystic kidney disease, and renal artery stenosis. All these diseases decrease GFR, and when GFR decreases, the body activates renin-angiotensin system in an attempt to increase GFR. And whenever renin-angiotensin system is activated, it causes hypertension through multiple mechanisms. For example, it stimulates the secretion of aldosterone from adrenal gland, which then causes sodium and water reabsorption in the kidneys. It's important to remember which drugs can cause hypertension. NSAIDs act just like aldosterone. It increases sodium and water reabsorption in the kidneys. Steroids, just like cortisol, increases the effects of epinephrine and norepinephrine, which then cause vasoconstriction and hypertension. Monoamine oxidase inhibitors increase the levels of tyramine in the body, which increase the levels of norepinephrine in the body, and norepinephrine causes vasoconstriction and hypertension. Combined OCPs have progesterone, which act just like aldosterone, and progesterone increases sodium and water reabsorption in the kidneys, just like aldosterone. In pregnancy, the levels of progesterone increases in the body, which increases sodium and water reabsorption in the kidneys. In coarctation of aorta, the blood flow to the kidneys decrease. So GFR decreases. So to increase GFR, the body activates renin-angiotensin system, and renin-angiotensin system then cause hypertension through multiple mechanisms. Home BP monitoring means that the patient records his blood pressure through a blood pressure machine. And ambulatory BP monitoring means that an automated machine is attached to the patient's body, and this machine records blood pressure of the patient every 30 minutes or 1 hour throughout the day and night. According to NICE guidelines, if the first blood pressure reading is above 140/90, take a second reading in the same consultation. So, in the exam, if you are asked a patient's blood pressure is more than 140/90 for the first time, what is the next step in management? So the next step in management is not home BP monitoring or ambulatory BP monitoring or starting an antihypertensive drug. The next step in management will be to take a second reading in the same consultation. Then use the lower of the two readings for management. For example, the first reading was more than 140/90 and the second reading was less than 140/90. So this is a normal patient. This patient does not require home BP monitoring or ambulatory BP monitoring. For home BP monitoring or ambulatory BP monitoring, the patient will record his blood pressure for at least 4 days and preferably 7 days. He will record blood pressure 2 times a day, then discard day 1 reading and take average of the remaining readings. If that average is more than 135/85, then this patient is hypertensive. And if it is less than 135/85, this is a normal patient, not hypertensive. So look at this reading. When you are recording blood pressure in the clinic, the cutoff value is 140/90. The patient will be said to be hypertensive if blood pressure is more than 140/90. But when you are recording blood pressure at home, then the cutoff value will be 135/85. In hypertensive patients, you will do these investigations. There are three purposes for these investigations. Number one, to find out any secondary cause of hypertension. Number two, to find out any complication of hypertension. And number three, to assess the cardiovascular risk of hypertension. In urinalysis, you will check proteins and RBCs to rule out CKD. CKD can cause hypertension and hypertension can cause CKD. You will check glucose to rule out diabetes, because if a hypertensive patient is also diabetic, it increases cardiovascular risk. You will also look for causes to rule out glomerulonephritis, which can cause hypertension. You will check glucose to rule out diabetes. you will check renal function test to exclude CKD. You can check potassium to exclude hyperaldosteronism, which is the most common secondary cause of hypertension. You can do ECG to exclude left ventricular hypertrophy. When pressure in aorta is high, it's difficult for the left ventricle to pump blood into the aorta. So, to overcome this issue, the left ventricle undergoes compensatory hypertrophy to produce enough force to push blood into the aorta. So, the left ventricle undergoes hypertrophy, resulting in left ventricular hypertrophy. You will check lipid profile because dyslipidemia can cause atherosclerosis, and atherosclerosis increases cardiovascular risk. When a patient is labeled as hypertensive, they will have to make some lifestyle changes in addition to taking antihypertensive drugs. It's important to remember for exam that the best lifestyle change which can most effectively decrease blood pressure is to lose weight. Salt intake should be decreased to less than 6 grams per day. 6 grams is about 1 teaspoon. Normally, a person takes 8 to 12 grams per day. Stop smoking, decrease alcohol consumption if the person is already taking alcohol. Regular exercise, decrease coffee, increase vegetable and fruits intake, and encourage relaxation. This slide is very important for examination point of view. According to NICE guidelines, if age is less than 55 years, then the first line drug is ACE inhibitor. And if age is more than 55 years, the first line drug will be either a calcium channel blocker or a diuretic. For examination point of view, there are two important points to remember here. Number one, calcium channel blocker is better than diuretic because calcium channel blockers have comparatively less side effects and it can control blood pressure more effectively. Number two, the diuretics of choice are chlorthalidone and indapamide. You can also use hydrochlorothiazide, but chlorthalidone and indapamide are preferred. So these 2 points are important to remember for exams. If a patient is taking ACE inhibitor and blood pressure is still not controlled, then you will combine ACE inhibitor with either calcium channel blocker or a diuretic. And if a patient is taking calcium channel blocker or diuretic and blood pressure is still not controlled, then you will combine this with ACE inhibitor. If blood pressure is still not controlled, you will combine all the three drugs, that is ACE inhibitor, calcium channel blocker, and diuretics. So in first line, you use one drug, in second line, you use two drugs, and in third line, you use three drugs. 10% of the patients will proceed to fourth line. So if you are working as a general practitioner and the patient is taking three drugs and blood pressure is still not controlled, you will refer that patient to specialist. There are certain special conditions in which we override the ACD rules. ACE inhibitors, calcium channel blockers, and diuretics that we studied in the previous slide. In patients of CKD, the drug of choice will always be ACE inhibitors, regardless of the age. What ACE inhibitors do is it decreases intraglomerular pressure, and so it slow disease progression. In BPH, we use alpha blockers. Alpha blockers relax bladder, neck, and prostate, so it improves the urinary flow. In osteoporosis, we use thiazide diuretics. Thiazide diuretics decrease calcium loss in urine, so calcium keeps the bones strong. In angina, the drug of choice will be beta blockers. Beta blockers decrease the heart rate. By decreasing heart rate, we decrease the oxygen demand of the heart. So angina attacks are prevented. In post-myocardial infarction patients, the drug of choice are also beta blockers because beta blockers decrease heart rate, decrease the oxygen demand, and by decreasing oxygen demand, we not only decrease the risk of another MI, but also the risk of arrhythmias. It's very important to know about the side effects of antihypertensive drugs. ACE inhibitors can cause hyperkalemia because aldosterone increases potassium excretion in the kidneys. But what ACE inhibitors do is it decreases aldosterone secretion, so potassium excretion is decreased and it results in hyperkalemia. Hyperkalemia can be very dangerous. It can be life-threatening because it can result in cardiac arrest. Calcium channel blockers cause arteriolar dilatation, which increases capillary hydrostatic pressure that result in fluid leakage into the tissues. So it causes ankle edema. Diuretics can cause hypokalemia because it increases potassium excretion in the kidneys. Hypokalemia can cause cardiac arrhythmias, and cardiac arrhythmias can cause fatigue and dizziness. So, when in an exam you are asked a patient is taking diuretic and he presented with fatigue and dizziness, what may be the possible cause? Always think about hypokalemia. ACE inhibitors are contraindicated in pregnancy because it can damage the fetal kidneys. What is the most teratogenic drug in the whole pharmacology? It is ACE inhibitors. What is the most dangerous drug in pregnancy? It is ACE inhibitors. So, ACE inhibitors is a big no in pregnancy. ACE inhibitors are also contraindicated in bilateral renal artery stenosis because renal artery stenosis decreases GFR and ACE inhibitors can further decrease GFR. So it can result in acute renal failure if GFR is decreased too much. Calcium channel blockers are contraindicated in AV conduction defects because in AV conduction defects, electrical impulses cannot pass through the AV node easily, and calcium channel blockers further decrease the conduction of electrical impulses in the AV nodes. In diabetic patients, diuretics can increase the blood glucose levels. In gout patients, diuretics can increase the uric acid levels, so it can precipitate a gout attack. In hyperlipidemia patients, diuretics can increase the levels of LDL and triglycerides. And in pregnancy, the diuretics can decrease the plasma volume, which then decreases the placental perfusion. The drugs that can be used in pregnancy include labetalol. According to NICE guidelines, labetalol is the drug of choice for hypertension in pregnancy. Calcium channel blockers can also be used. Methyl dopa is a traditional choice. It is still used, but it is less preferred due to its side effects, for example, sedation and depression. Hydralazine can be used in acute severe hypertension, uh, but remember that it is not a first-line drug in acute hypertension. It is used only when IV labetalol or IV calcium channel blockers are not available or not suitable. So if labetalol and calcium channel blockers not available, you can use hydralazine in acute severe hypertension. Hydralazine is not used for chronic management of hypertension. ACE inhibitors and ARBs are absolutely contraindicated in pregnancy because they can damage the fetal kidneys. And diuretics are relatively contraindicated because they decrease plasma volume, which can then decrease placental perfusion. In non-diabetic patients, the blood pressure target depends upon age. If age is less than 80 years, then the blood pressure target is 140 by 90. And if age is more than 80 years, then blood pressure target is 150 by 90. So in young patients, we keep the BP target, we aggressively control the blood pressure to prevent stroke and MI. And in older patients, we allow slightly higher BP to avoid falls, dizziness, and renal hypoperfusion. In diabetic patients, the BP target depends upon whether diabetes is complicated or uncomplicated. In uncomplicated diabetes, the blood pressure target is 140 by 80. As compared to non-diabetic patients, we keep the target a little tighter to prevent microvascular damage such as retinopathy and nephropathy. If diabetes is complicated by renal, foot, eye, or cardiovascular complications, then the BP target is 130 by 80. It is comparatively even more tighter to provide maximum protection for organs that are already damaged. Hypertensive crises include two entities, hypertensive urgency and hypertensive emergency. In both hypertensive urgency and hypertensive emergency, systolic blood pressure will be more than 180 or diastolic blood pressure will be more than 120. However, in hypertensive urgency, there will be no signs of end organ damage, while in hypertensive emergency, there will be signs of end organ damage. So, the basic difference between hypertensive emergency and hypertensive urgency is that there will be presence or absence of end organ damage. If no signs of end organ damage, hypertensive urgency. If there are signs of end organ damage, then it is hypertensive urgency. When you receive a patient with hypertensive urgency and he is already on medications, then check compliance and then restart or optimize the dose of treatment. If the patient is not already on medications, then you have two options. The better option is to start a long-acting antihypertensive according to guidelines, that is ACE inhibitor, calcium channel blocker, or diuretics that we studied earlier. Another option is to give oral captopril 6.25 milligrams or 12.5 milligrams. When you decrease the BP to a safe limit, then you can send the patient home with long-acting antihypertensive according to guidelines. Aim for BP less than 160 by 100. However, BP should not be lowered by more than 25 to 30% over the first 2 to 4 hours, because if you abruptly decrease the blood pressure, it can cause hypoperfusion in the brain, heart, or in the kidneys. In hypertensive emergency, systolic blood pressure will be more than 180 or diastolic blood pressure more than 120, and the patient will have signs of end organ damage. So what are the signs of end organ damage? Confusion, headache, blurred vision, encephalopathy, for example, seizures, nausea, vomiting, chest pain, shortness of breath, or papilloedema. If you are working as a general practitioner in primary care, open IV access and refer patient urgently to the hospital because it is a medical emergency. A 71-year-old man is referred to the outpatient clinic for advice on his antihypertensive treatment. He has a history of stroke and long-standing uncontrolled hypertension. His blood pressure recordings at home and at his surgery within the past 2 weeks were 188 by 216 and 176 by 208. His therapy comprised ramipril, atenolol, and amlodipine. These are his lab results. Which of the following is most likely contributing to the treatment failure? Antacids, NSAIDs, table salt, or pseudoephedrine? The correct answer is NSAIDs. NSAIDs increases sodium and water reabsorption in the kidneys. This increases the blood volume. The heart pumps more blood, and so blood pressure increases. Table salt can also increase blood pressure, but not as much as NSAIDs. Here, blood pressure is very high, so table salt is less likely answer. A 70-year-old man admitted with left lower limb swelling and pain, diagnosed as DVT, where heparin was started. He has a history of diabetes mellitus, hypertension, and chronic heart failure. He is on insulin, furosemide, and enalapril. Blood pressure is 110 by 70. Heart rate is 76. Oxygen saturation 94%. Sodium 135, potassium 6, chloride 107, urea 7.9, creatinine 120, APTT 50, and prothrombin time is 14. Which of the following medications should be discontinued at this stage? Insulin, enalapril, heparin, or furosemide? The answer is enalapril, because this patient potassium is 6, which is pretty high. Upper limit is 5.1 and this patient has 6 potassium. So this patient has hyperkalemia, and hyperkalemia can be dangerous it can cause cardiac arrhythmias. ACE inhibitors such as enalapril increases potassium levels in the body. So this patient's potassium is high because of enalapril. So we will stop it. A 36-year-old man with multiple health problems presents to the emergency department with an episode of bronchospasm. He has a history of asthma and hypertension. He is undergoing a medication review. Which of the following medications is most likely to be responsible? Salmeterol, atenolol, ramipril, aspirin. The answer is atenolol. Beta blockers are an important cause of bronchospasm in asthma patients. Remember that aspirin and NSAIDs can also cause bronchospasm, but beta blockers are more important. So here atenolol is the most appropriate answer. 56-year-old man comes for follow-up. He has shortness of breath on exercise, which have increased over the past few months. He became unable to walk more than 200 to 300 meters on the corridor and cannot climb the stairs easily. He has history of hypertension and currently on amlodipine 5 milligrams OD and indapamide 2.5 milligrams OD. On examination, he has bilateral basal crackles and mild pitting ankle edema. Blood pressure is 188 by 96, heart rate 79 per minute. Hemoglobin 133, sodium 138, potassium 4.2, and creatinine is 133. Which of the following is the most appropriate next therapy? Spironolactone, furosemide, bisoprolol, or lisinopril? The correct answer is furosemide. This patient has volume overload because he has shortness of breath, he has bilateral basal crackles in the lungs, and he has ankle edema. So this volume overload should be addressed as soon as possible. Although he is also taking indapamide, which is also a thiazide-like diuretic, but it is not so useful for decreasing volume overload. Loop diuretics like furosemide are better in decreasing the volume overload. His blood pressure is also pretty high, which is 188 by 96, and it should be decreased immediately. But here the primary concern is volume overload and not blood pressure. The drug of choice for blood pressure for hypertension and heart failure is ACE inhibitors such as lisinopril, but we will not choose it here because our next therapy, our most important concern is volume overload. So our most appropriate next therapy will be furosemide to decrease the volume overload and then address the blood pressure. A 66-year-old man with hypertension comes to the clinic for a follow-up. He is currently taking a combination of losartan and amlodipine, which is failing to keep his blood pressure within target. Examination is unremarkable. His blood test and renal function profile were within the normal limits. What is the most appropriate next step, assuming he has no relative No relevant contraindications. Add ramipril, add atenolol, add doxazosin, or add indipamide. So the answer here is add indipamide. This patient is already taking ACE inhibitors and calcium channel blockers, but his blood pressure is still not controlled. So next we will add a diuretic such as indipamide. So he will now move to the third line treatment in which we use three drugs: ACE inhibitors, calcium channel blocker, and diuretic. A 76-year-old male presents for routine checkup. Blood pressure is 150 by 152 by 95 first reading. What is the most appropriate next step? Ambulatory blood pressure monitoring, start antihypertensive medication, repeat blood pressure twice during the same clinic visit, or home blood pressure monitoring. The answer here is repeat blood pressure twice during the same clinic visit. This is not a diagnosed blood pressure hypertensive patient. He came for the first time, and the first reading of blood pressure is high, 152 by 95. So according to NICE guidelines, you will check the blood pressure again during the same visit and then use the lower of the two readings to decide further management. Thank you very much and good luck for your exams.